Welcome back to the deep dive. Today, we're doing what I'd call a mandatory preoperative review. We're scrubbing in, basically.
Yep.
We're going for a really highly technical, granular examination of, well, the workhorse of sports orthopedics, anterior cruciate ligament reconstruction.
Mhm.
And we are not just skimming the textbook here. We are dissecting the principles, the biomechanics, and really the meticulous technique you need to get a durable outcome.
And that's absolutely the right focus. I mean, when we look at all the source material, the textbooks, the big registries, the hard science research, it just confirms that ACL injury is one of the biggest problems we face.
The scale is just massive.
It's huge. We're talking about an estimated, 130,000 to 200,000 reconstructions every single year in the U.S. alone.
And that's not even counting the rest of the world.
Right. It's 400,000 worldwide.
Yeah.
That is just a massive volume of ligament failure that demands a predictable solution.
And while, the conference halls are perpetually split on which graft is best, our deep dive today focuses on the technique that really set the standard.
The bone patellar tendon bone.
The BPTB autograft. It remains the established, recognized gold standard as Hospinar and Miller cemented in the literature. And for good reason.
So the mission then is to really unpack that gold standard. We need to understand why it's the benchmark. We're talking from its historical development, its biomechanical superiority, right down to the specific tunnel placement.
The nuts and bolts.
The nuts and bolts and the tensioning protocols that ensure we restore both stability and, crucially, full range of motion. We're treating this like it's the final check before we pick up the scalpel.
I like it. So let's start with history. You look at that clean bone plug and the interference screw setup today, and it feels almost simple. But this technique was built on decades of, frankly, frustrating failures. It wasn't always this refined, was it?
Oh, far from it. Not at all. I mean, the journey of ACL reconstruction, it really reflects this constant push for a graft that is both strong and critically integrates biologically.
Right.
Early procedures often failed because they either weren't strong enough or they didn't heal reliably inside the joint.
So the first major conceptual shift, that came back in '63 with Jones's description, right? He pioneered the whole idea of using the central third of the patellar tendon.
Exactly.
But the innovation wasn't just using the tendon itself. It was maintaining that distal attachment to the tibial tubercle while transferring the proximal bone block up to the femur.
Right, but that was still, a relatively extra-articular or over-the-top procedure. It relied on that strong distal attachment for its support.
It wasn't anatomical yet.
Not truly anatomical. The movement toward that really accelerated when Marshall and his colleagues modified the approach in 1979. They started to incorporate the prepatellar fascia and the central part of the quad tendon, but more importantly, this is where they began running the reconstructed ligament through a dedicated tibial tunnel.
And that's the moment. That's when we started aiming for a more anatomical trajectory, trying to mimic the native ligament right inside the knee. But the true game changer, the moment the BPTB construct we know today was born, that came from Clancy and his group in 1982.
That is the pivotal step. Clancy described harvesting the graft with a block of patellar bone. And why?
For bony healing.
To finally achieve bony union on the femoral side, that bone plug on the femur provided a reliable, predictable fixation point that soft tissue just couldn't match. This also formalized the full BPTB construct, harvesting a tibial bone block distally. That bone-to-bone healing element is what elevated this procedure above everything else.
That bony integration is absolutely the foundation of its gold standard title. Let's get into the biomechanical specs because this is where the BPTB just separates itself from the soft tissue pack. Why, from a pure tensile strength perspective, is this the one we benchmark against?
Well, the data really speaks for itself here. BPTB offers superior initial stiffness and a much higher energy to failure compared to, say, hamstring or allograft options. But like you said, the major benefit is in the fixation.
It's all about the fixation.
It is. The bone plugs allow us to achieve this predictable, rock-solid initial fixation because we are capitalizing on bone-to-bone healing,
Right.
which is facilitated by that interference screw locking the plug inside the tunnel.
It's like comparing structural steel to high tensile wire. One relies on pure strength, the other relies on a foundation. You're putting a metal anchor into cement rather than just relying on a soft tissue suture through a suspension point. You get predictable, immediate, strong purchase.
And that predictable fixation is absolutely key. I mean, look at the numbers cited in the literature. A wider BPTB graft, like a 14 to 15 millimeter one, has been measured at approximately 168% the strength of a normal native ACL.
That's incredible.
It is. And even our current standard, the 9 or 10 millimeter grafts, they still possess greater tensile strength than the original ACL they're replacing. This is why we can be so aggressive with our accelerated rehab protocols. The construct can handle that early load.
So if we're framing this for the listener, the BPTB is the heavy-duty bulldozer of grafts. It's tough, it heals reliably through that bone integration, and it sets the absolute highest bar for immediate post-op stability. It allows us to push patients back into motion, knowing that foundation will hold.
Right, so now, shifting for the benchtop, to the patient, identifying those high-risk individuals is the next crucial step. This injury isn't random. It's often structurally predetermined.
It really is.
And studies have strongly correlated ACL injury risk with these underlying anatomical factors, and the primary one is intercondylar notch stenosis.
It's a classic case of physics meeting biology. It really is.
Yeah.
When the notch, that little opening where the ACL lives, is too narrow, the ligament is essentially trapped. It gets sheared during rotational and pivot moments. Soriel and Freeman demonstrated this prospectively in high school athletes. The ones who tore their ACLs had statistically significant stenosis compared to matched controls.
And Harder's group took that anatomical assessment even further, using CT scans. They isolated the structural culprit, which was a larger lateral femoral condyle width. It acts like a big shoulder, just narrowing the available space for the ligament, and that leads to the stenosis. The consensus from meta-analyses is just crystal clear. Decreased notch width predisposes patients to injury.
And we don't even need an injury to see this risk. MRI analysis of the contralateral, the uninjured knee in these patients, reveals these structural warning signs. You see decreased intracondylar notch width, you see an increased thickness of the bony ridge, and a decreased ACL volume. These are high-risk knees just waiting for the wrong pivot.
This structural predisposition is one element, but we have to talk about the stark gender disparity. Women suffer ACL injuries at 4 to 8 times the rate of men in similar high-risk sports. It's not just a statistic. It's a clinical reality we confront every single day.
And the explanation is truly multifactorial. It's not one thing. Intrinsically, women often exhibit that narrower notch width and critically an increased lateral tibial plateau slope.
The SOAP.
That increased slope is a geometric nightmare. Think of the tibial plateau like a ramp. The steeper the ramp, the harder the ACL has to work to prevent the femur from sliding forward. It's a dynamic anterior subluxation. Bainen's research showed a frightening 21.7% increase in non-contact injury risk for each degree of increase in that slope.
That's a huge number for every degree.
It's massive.
And then you have to layer on the extrinsic factors. Hormonally, we see increased injury rates during the preovulatory and ovulatory phases, which coincides with the estrogen surge.
Right.
Estrogen has been hypothesized to affect the laxity and mechanical properties of collagen fibers, though the exact mechanism is, still being refined. And then genetically, there's a link to the lack of the CC genotype of COL5A1, which suggests some patients are just built with less durable collagen to begin with.
So it's a perfect storm. You have narrow hardware with the notch, you have faulty geometry with the slope, and you have this dynamic instability influenced by biochemistry. So once that storm hits, that characteristic deceleration, pivoting injury with the audible pop, the pain, the massive swelling, we transition to diagnosis.
And the physical exam is so key. We rely on the Lachman test, which is the most specific at 94%, and the pivot shift test, which is the most sensitive at 98%.
Yeah.
You really need both to confirm the grade of instability and the rotational deficit.
Which brings us to that critical decision point, operative versus non-operative management. And historically, there were attempts at conservative treatment. Some of the older studies, like from McDaniel and Dameron, showed 70% of conservatively treated patients returned to strenuous sports. Jiva's group reported 59%. These studies, I think, often create a false sense of security.
That sense of security just completely evaporates when you filter the data by activity level.
Yeah.
If your patient is a high-demand pivoting athlete, conservative management is, it's frankly a recipe for secondary disaster.
It is.
Noise's study showed that 55% of active patients treated non-operatively sustained a significant re-injury within 1 year, and only 35% returned to strenuous sports long-term. Barrick and his colleagues had similarly grim results.
I often tell patients this. Choosing conservative care for a young, high-demand athlete who insists on playing basketball or soccer is like sending a race car out on the track with bald tires and a failing transmission. You know what the inevitable outcome is going to be.
Yeah.
It's a slow-motion, internal, catastrophic failure of the joint.
Precisely. The decision is driven by lifestyle, not by age. Blanchard's group found excellent results in highly active patients over 40. But for the high-level participants, your level IN2 sports reconstruction is really the only way to safeguard the joint. And what's more, the decision is time-sensitive because of that secondary pathology.
The clock is ticking on the menisci and the cartilage. Grannon and his team found that the odds of developing cartilage lesions increased by almost 1% for every single month that elapsed between the injury and the reconstruction.
Wow, 1% a month.
Yeah, and time to surgery longer than 12 months was an independent predictor of significant articular injury. Every month of instability is just chewing away at the joint surface.
And if we look at the cost-effectiveness argument, even from a societal healthcare model, early reconstruction is found to be less costly and more effective than a delayed optional reconstruction.
Right.
By providing that stability early, we protect the menisci. We reduce the need for complex, late-stage meniscal repairs, or even worse, total meniscectomies, which, as we'll get into, are the single biggest predictors of future arthritis.
So once that decision for reconstruction is made, we cannot rush the timing. The knee has to be ready. Historically, operating too soon, like within the first week, was a known setup for disaster.
Absolutely. The high risk of arthrofibrosis, which Shelburne and his group showed.
That was the fear, that stiff knee setup.
Right. But modern accelerated rehab and improved surgical techniques have really mitigated that. Coak's meta-analysis confirmed that with contemporary technique, we can operate earlier without increased stiffness rates. The consensus now, articulated by Hunter's group, shifts the focus entirely away from a specific number of days and onto the preoperative condition of the knee.
And that is the critical takeaway for any surgeon in training. If they don't have it on the table before you start, they're not going to get it back post-op. Our absolute mandatory pre-op criteria are minimal or no swelling, good voluntary quad control, and most critical one,
Full range of motion.
full symmetrical range of motion, including full hyperextension that matches the contralateral side. If the knee is angry, if it's swollen or stiff, we wait.
Absolutely. Operating on a swollen, stiff knee is just inviting arthrofibrosis. It makes the surgery almost irrelevant to the final functional outcome. So once we meet those criteria and we move to the OR, the very first intervention is the examination under anesthesia, the EUA.
It's non-negotiable. We have to establish the patient's baseline laxity. We do the Lachman and pivot shift tests on both knees. Comparing the injured side directly to the contralateral normal knee is just essential to quantify the magnitude of that laxity.
And that pivot shift under anesthesia, it's arguably the most revealing moment of the entire procedure. Because the patient's muscles are completely relaxed, the test fully demonstrates the functional loss and the rotational instability that's been imparted by the torn ligament.
Things they might have been guarding against in the clinic.
Exactly. What may have been masked by guarding in the clinic. It is the gold standard for rotational assessment.
The diagnostic arthroscopy follows. We go in, we're looking for the stump, but we have to be extremely wary of that pseudostability trap. Sometimes the remnant of the torn ACL scars down to the PCL, giving you this initial appearance of an intact, taut ligament. If you don't look closely, you might miss the true instability.
And in those deceiving cases, we use a position change. Shifting the leg into the figure of 4 position really helps open up the intercondylar notch, and it allows for an adequate assessment of that proximal femoral attachment site. It clearly shows where the ligament has avulsed or scarred down.
Right.
So once we confirm the tear and we address any associated pathology like meniscal tears, then the clock starts on the harvest.
Okay, this is where the surgical precision has to be just paramount because donor site complications begin right here. We start with the vertical incision from the inferior pole of the patella down to about 1 centimeter medial to the tibial tubercle. We develop our flaps, protecting the infrapatellar branch of the saphenous nerve as best we can, though some numbness is often unavoidable.
And we have to be so precise on the dimensions. We use a 9 or 10 millimeter catamaran blade, and we ensure we harvest no more than 1/3 of the patellar tendon width. Maintaining tendon integrity is the immediate goal. The bone plugs must be sized to match the desired graft length, so generally 25 millimeters proximal and distal to the tendon insertion points, and cut to a depth of about 8 millimeters.
And that 8 millimeter depth on the bone plugs is a major quality control point, especially on the patella. When you're cutting that patellar plug, you have to keep the oscillating saw blade at a 45-degree angle relative to the perpendicular surface.
The angle is key.
It's so key. If you go too deep or if you fail to maintain that angle, you create stress risers that are guaranteed to cause a postoperative patellar fracture. You really only get one shot at this.
So once it's harvested, the graft requires meticulous preparation on the back table. We trim the bone plugs to the desired final diameter, 9 or 10 millimeters, and we round the edges to ensure a smooth passage through those tight bone tunnels. Importantly, the tibial plug is often the one we plan to place in the femoral tunnel.
And why is that?
Well, it's generally less curved,
Mm.
and it just fits better into the reamed femoral socket, and that maximizes the bone fill.
Exactly. And bone fill equals fixation surface area. We drill 3 small holes in the patellar plug and usually one in the tibial plug for our number 5 non-absorbable sutures. And these aren't just for passing the graft, they are essential for graft handling, for tensioning, and for securing the provisional fixation.
And we need that sweet spot for length. For standard interference screw fixation, a total graft length between 92 and 97 millimeters is required to ensure the bone plugs are perfectly seated at the appropriate depth within the tunnels.
Yeah, if the graft is too short, you're either compromising femoral fixation or tibial fixation. If it's too long, you're stuffing way too much soft tissue into the joint line.
And a quick technical detail on the sizing. Some data from Gotland's group suggested no significant difference in knee stability between a 9 millimeter and a 10 millimeter diameter graft. So this offers a little bit of flexibility. If the tendon is a little thinner, a 9 millimeter harvest is perfectly adequate.
Right, and it might reduce the chance of donor site pain slightly.
Exactly. So with the graft secure, we turn back to the knee for the intra-articular prep. The goal now is to establish the perfect environment for the new ligament, and that starts with the notchplasty. We have to eliminate any risk of graft impingement, especially in full extension.
Impingement is the most common mechanical reason for loss of motion, period.
It is. So we meticulously remove the ACL remnants, being really careful not to violate the PCL. We clear the lateral wall, using the motorized burr cautiously. If you're conservative here, you guarantee a problem later.
Odenston and Gilquist provided some of the early benchmarks, suggesting restoring the notch width to 21 millimeters, while Berg defined adequacy based on the notch width index, or NWI, needing to be at least 0.250.
And the required degree of that notchplasty is directly linked to your tunnel placement. Howell's findings confirm this. If you use a more anterior tibial tunnel, which is common in the transtibial technique, you may need to remove up to 6 millimeters of bone from the anterior edge of the lateral wall of the notch roof to prevent the graft from rubbing in extension. It's a technical trade-off.
I think we should always advocate for a generous notchplasty, ensuring that that lateral wall is cleared all the way back. And while we're talking about bony geometry, we have to spend a moment on the residence ridge.
Oh, yeah.
This is the anatomical landmark that separates an experienced ACL surgeon from a beginner.
It absolutely is. The residence ridge is that small, bony prominence located right at the anterior border of the PCL attachment. If you don't identify and remove this ridge while continuing the notchplasty posteriorly, you are guaranteed to inadvertently place your femoral tunnel too far anterior.
And an anterior femoral tunnel is a structural failure. It causes immediate graft stretching and flexion. It's a critical track to avoid.
It's the point where you accidentally move from an anatomical placement to an old-school non-isometric placement, and you're just setting the patient up for laxity or loss of flexion. The notchplasty isn't just about making space. It's about correcting pre-existing stenosis and ensuring a clean trajectory for the graft.
So now for what I think is the highest stakes part of the whole procedure, the tunnels. The difference between success and failure often comes down to just millimeters of tunnel placement. And starting with the tibial tunnel, we are perpetually fighting the anterior trap.
The anterior trap is the reason for so many early failures. Excessive anterior tibial tunnel placement causes the graft to impinge on the roof of the notch and extension, and that leads to loss of motion, fraying, and ultimate failure. We have to fight that natural tendency to place it too far forward.
So our routine technique, we set the tibial drill guide at 55 degrees. And using arthroscopic landmarks, the crucial placement point is 7 millimeters anterior to the PCL. It aligns perfectly with the posterior border of the anterior horn of the lateral meniscus. That's what Morgan described. That is the anatomical sweet spot.
The external starting point is easy enough. It's about a finger breadth medial to the tibial tubercle and 2 finger breadths distal to the medial joint line. But once the guide pin is placed, we have to ream the tunnel carefully and critically, smooth those intra-articular edges meticulously with a rasp.
Any sharp edge is just a stress riser waiting to chew through your graft.
Exactly. So then, moving to the femur, we typically use the transtibial technique. The preferred position for the femoral tunnel needs to be within that native ACL footprint. So generally between 1:30 and 2 o'clock for a left knee, or 10 and 10:30 for a right knee. We aim for about 6 or 7 millimeters anterior to the over-the-top position.
The major potential catastrophe here is violating the posterior cortex. If you ream too deep or you aim too posterior, you blow out the back wall of the femoral tunnel, and this is an avoidable disaster.
Completely avoidable.
To prevent it, we insert the guide pin only to a depth of 35 millimeters or roughly 1.5 inches. That ensures there is adequate bone stock posteriorly for fixation.
We always use the reamer by hand initially, just to create a small footprint indentation. This lets us confirm the correct position and, most importantly, visualize the integrity of the posterior cortex before we commit to full reaming. Because if you blow that posterior wall, you have to abandon interference screw fixation. The screw will just push the bone plug right out the back.
And if that violation occurs, the procedure drastically changes. You have to convert to a screw and post-fixation laterally through a whole separate incision. It's what Bush-Joseph described. It just adds complexity, morbidity, and cost. Prevention is the only treatment.
We should probably pause for a second on the conceptual shift from isometry to anatomic zones. The older technique obsessed over finding a single point that remained isometric, meaning the distance between the two attachments stayed the same throughout the range of motion.
But the native ACL isn't isometric. It's a dynamic restraint system with two bundles, the anteromedial and the posterolateral, that lengthen and shorten differently depending on knee position.
Right.
So by focusing on replicating the anatomic footprint in that 1:30 to 2 o'clock range, we accept the non-isometric nature and we achieve functional stability. So time spent intra-articularly testing for isometry is largely unnecessary if our anatomy is correct.
So once the tunnels are perfect and the edges are smooth, we pass the graft. We pull the sutures through the tunnels and seat the bone plugs. And the orientation of the femoral plug is a crucial subtlety. The cancellous bone surface of that femoral plug must face anterolaterally in the tunnel.
And that orientation is essential for fixation. It allows the interference screw to engage the cancellous surface, which is softer and more pliable, and that facilitates compression and bony integration. If you insert the screw against the cortical surface of the plug, you risk fragmenting the plug or disrupting the ligamentous attachment.
The fixation is typically achieved using that interference screw strategy, which Kurosaka introduced. This system offers superior mechanical properties, increased ultimate failure load, and constructs stiffness compared to the older methods. And while we can debate metallic versus absorbable screws endlessly, the clinical outcomes for laxity and scores are generally equivalent at 5 years.
And we select the screw size based on the tunnel-to-plug gap. A 7 millimeter screw if the gap is tight, a 9 if it's larger, but the screw has to engage at least 75% of the bone block. And while divergence, the screw not being perfectly parallel, can happen, studies like Scuderi's review showed that divergence of less than 30 degrees rarely correlates with poor long-term outcomes, provided the bone fill and the initial stability are robust.
Okay, now the final, most delicate step. Graft tensioning. This is the moment we dial in the stability. It's where the surgeon's judgment is just paramount.
Absolutely.
Too loose, and the patient ends up with a positive pivot shift and long-term instability.
And too tight, you guarantee a loss of motion, which is just a devastating outcome. Because BPTB is the stiffest construct, it requires precise tension. Research suggests an initial tension of approximately 90 newtons provides the best stability without over-constraining the knee.
And critically, the position of tensioning. Boski-Ostro's work proved that tensioning the graft at 30 degrees of flexion consistently over-constrained the knee. It sets up an immediate post-operative flexion contracture.
Yeah, you're building in a problem.
Therefore, we follow Neighbor's protocol, tensioning and fixing the graft in full passive extension. This is the key maneuver to ensure the knee achieves and maintains full extension post-operatively.
So once it's fixed on the femur, we address the tibia. We use an interference screw if the plug end is within 5 millimeters of the extra-articular edge. If it falls short, we have to resort to post-fixation, tying the sutures over a screw and washer posts placed distally. It's a reliable backup, but we prefer the interference screw for that compressive force.
And before closing, the final, crucial intra-articular step, the scope check. We use the arthroscope to check graft clearance from the notch roof, confirming zero impingement both at 15 degrees of flexion and, critically, in full extension. If there is a rub, we go back and we burr the roof until it's clear. No excuses.
All right, so we've executed the gold standard technique perfectly, but the story isn't over. We have to anticipate and manage the consequences of the intervention. Donor site morbidity and complications are inherent to the BPTB procedure.
Yeah, the intraoperative risks, as we discussed, they include patellar fracture during harvest, which Simonian described as potentially occurring early post-op or even years later, though it's rare. We also face the risks of technical error, tunnel misplacement, graft fragmentation from overtensioning, and simple sutural laceration during passing.
Postoperatively, the avulsion of the patellar or tibial tendon is an extremely rare but devastating event, though most occur within the first year. But the real enemy, the true Achilles heel of ACL reconstruction, is the loss of motion.
That is the most common persistent complication. Loss of full extension is functionally disastrous, and it's often the result of the technical pitfalls we talked about. An inadequate notchplasty or an anterior tibial tunnel. Loss of flexion, conversely, usually results from an anterior femoral tunnel.
The classic mistake of neglecting the residence ridge. Beyond function, patellofemoral pain is a known complaint. It affects between 5 and 19% of patients. Sachs and his group found a positive correlation between this pain and the presence of a postoperative flexion contracture. It just reinforces this central narrative. If you lose motion, you lose the knee.
And this is why Shelburne and Trumper's work on rehab is so foundational. They argued that anterior knee pain isn't fundamentally a consequence of taking the patellar tendon. It's prevented by an aggressive program emphasizing early motion and, specifically, achieving full knee hyperextension. Achieving symmetry and extension is the ultimate objective measure of success in that recovery period.
Now, let's leverage the power of some real-world data to justify this gold standard status. The Scandinavian ACL registries, which cover tens of thousands of reconstructions, they provide an unparalleled view of long-term graft performance.
And the registry data is decisive. BPTB autografts demonstrate a significantly lower revision rate at 5 years, 2.8% compared to hamstring autografts, which are at 4.2%.
That's a big difference.
It is. The Norwegian registry specifically showed that hamstring grafts carried nearly twice the risk of revision compared to BPTB at the 4-year mark. And furthermore, meta-analyses consistently confirm that BPTB results in decreased objective instability, a tighter knee-on post-operative pivot shift testing.
So while the hamstring lobby champions lower donor site pain, the BPTB camp really holds the cards on objective stability and long-term durability, minimizing that risk of re-rupture. This low revision rate and superior objective stability are why BPTB retains the gold standard designation, despite the necessary donor site morbidity. It's a trade-off for robustness.
However, regardless of the graft we choose, we have to address the ultimate long-term threat, the development of osteoarthritis. Reconstruction is prophylactic in the sense that it does reduce the risk of OA compared to leaving the knee untreated and unstable, but it doesn't eliminate it.
And the primary determining factor for long-term OA risk is not the ACL tear itself or even the reconstruction, but the associated secondary injuries. Specifically, the presence or need for meniscectomy. This is a profound distinction that the sources repeatedly highlight.
It's the catastrophic joint surface event. For isolated ACL reconstruction where the menisci were pristine or repairable, the OA prevalence is relatively low at long-term follow-up, sometimes 0 to 13%. But if a meniscectomy was required, that prevalence skyrockets to between 21 and 48%. The meniscus is the critical shock absorber, and removing it sets that degenerative cascade in motion.
Which means our focus in the OR has to be twofold. Achieve perfect stability and do everything possible to preserve or repair the meniscus. Furthermore, we know that loss of full extension postoperatively is also strongly associated with the later development of arthritis and chronic pain. The quest for stability must always be balanced by the quest for motion.
So finally, let's just briefly explore the new horizons that are changing our philosophy. Surgeons are constantly trying to improve stability by better mimicking the native anatomy. The double bundle, or DB technique, attempts to replicate the two bundles, the anteromedial and posterolateral of the native ligament.
The theoretical benefit there is improved rotational stability, and some RCTs have indeed shown that DB reconstructions can provide superior anterior and rotational stability and sometimes better functional scores compared to the traditional single bundle technique. It's arguably more anatomical.
But the clinical adoption has been slow. Brophy's group conducted cost-benefit analyses, and they found that the DB technique introduces significant surgical complexity, increased operative time, and cost, all without a clear, overwhelming functional benefit that justifies the expense for all patients.
So while it's biomechanically sound, it struggles on the cost-effectiveness front.
Exactly. And we're also seeing technical innovations like the all-inside technique, which uses special fixation devices to avoid that cortical disruption associated with standard full-length tibial tunnels. This modification has been linked to significantly lower narcotic consumption postoperatively, offering a better initial recovery.
Which is a big deal for outpatient surgery.
A huge deal. But perhaps the most intellectually stimulating new horizon pushes us completely out of the knee joint and into the brain. Functional brain MRI studies on patients with chronic ACL deficiency have revealed central nervous system reorganization in motor-related areas.
That is truly fascinating. It suggests that when the ACL tears, we lose more than a mechanical restraint. We lose a vital sensory organ, a proprioceptive input that contributes to the overall brain mapping and motor control. The CNS literally reorganizes itself to compensate for the deficiency.
Precisely. So this means that chronic laxity isn't just a local mechanical problem, it's a central nervous system issue. And the implications for rehabilitation are enormous. Our standard protocols might only address the mechanical, musculoskeletal aspect.
Yeah.
Future rehab may need modification protocols, specifically targeting CNS motor retraining and proprioceptive feedback loops, to fully resolve the long-term functional deficits that follow an ACL tear.
The ACL injury is forcing orthopedics to become neurologists. That is a profound realization.
It reframes the entire concept of full recovery.
So, to synthesize this deep dive, the BPTB autograft remains the benchmark, validated by major registries for its low revision rate and superior objective stability, which is rooted in its unique bone-to-bone healing fixation. We know that stability, accelerated rehab, and meticulous patient selection are paramount. And the biggest threat to the long-term success of the knee isn't the ACL tear itself, but the concurrent meniscectomy and the failure to achieve full symmetrical range of motion postoperatively.
And our technical mastery, from avoiding the resonance ridge during the notchplasty to fighting the anterior tibial trap and achieving 90 newtons of tension in full extension, is what separates a durable outcome from a revision case. And we rely on those registries to continuously refine those technical thresholds.
Which brings us to a final provocative thought for you, the clinician, to mull over during your next case. We've established that knee geometry, the narrow notch, the steep tibial slope, clearly predisposes specific high-risk patients, particularly women, to ACL injury. We can identify these geometric factors before they tear their ligament. So, given the profound long-term consequences of OA following injury and meniscectomy, should orthopedics and sports medicine be satisfied with simply fixing them after they break? Or, in light of the high risk and anatomical certainty, should we push for mandatory screening of young, high-risk athletes to identify these geometric factors and deploy targeted, prophylactic neuromuscular training to prevent the injury cascade from ever starting? That's the challenge that lies ahead.